Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with Gujarat Societies. So it's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant obstetrician from Salem and National Coordinator for Midlife Management Committee, FOXY. I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Sahiti, for the introduction. So it is my proud privilege to welcome one and all for this webinar of Tamil Nadu Federation Societies with Gujarat Societies, and with the blessings of none other than Dr. Alpesh Gandhi sir, who's a past president of FOXY and who's always been an inspiration and motivation to all of us FOXians. And we have our esteemed organizer for this program, Dr. Sampath Kumari ma'am, who's a past vice president of FOXY and also secretary of Tamil Nadu current secretary of Tamil Nadu Federation of Obstetricians and Gynecologists, and immediate past president of OXY, also a Senate member of Tamil Nadu Dr. MGR Medical University, the national corresponding editor of Jogi, and ma'am is also the retired director of Institute of Obstetrics and Gynecology at Chennai, and she received the first ICOG Distinguished General Council Member Award. And ma'am is also the presidential candidate for 2026. So seeking your all blessings and support for the upcoming elections in August. Over to you, ma'am, for the welcome speech.
Yes, thank you, Dr. Madhumita, for the nice words. Now, I welcome all the president and secretaries of Gujarat Society, Ahmedabad, Dr. Munjal and Dr. Aarti, and Anand Society, Dr. Kumud and Dr. Subina, and Himat Nagar Society, Dr. Sarfaras, and I think everyone has joined, Dr. Vishak, Gandhi Nagar Society, Dr. Mahesh Gupta and Dr. Rupa, and Bhavnagar Society, Dr. Nidhi and Dr. Pooja, Jamnagar Society, Dr. Nalini, Dr. Meg, Junagadh Society, Dr. Piyush and Dr. Devraj. If I have mistakenly spelling means, please excuse me. And the Mehana Society, Dr. Pankaj, and Navsari Society, Dr. Vaibhav and Dr. Akash, the Palanpur Society, Dr. Suraj and Dr. Rahul, Patan Society, Dr. Uday and Dr. Saik, and Porbandar Society, Dr. Hira and Jignesh, and Rajkot Society, Dr. Darshana and Dr. Tamna, and Surat Society, Dr. Ashwin and Dr. Rosi, Vadodara Society, Dr. Reshmi and Dr. Fras, and Valsad Society, Dr. Yogini and Dr. Neelam, Vapi Society, Dr. Deepthi and Dr. Saumya. And I welcome our Tamil TNFOG President, Dr. Vidya Prabhakar, and we have the two sessions. One is the e-motive bundle of the speaker by me, and the panel discussions of the PPH case by Dr. Meera Raghavan and the wonderful expert Dr. Mahesh Gupta, and the panelists Dr. Reshmi, Dr. Ashwin, Dr. Darshana, Dr. Dr. Kurosha, Dr. Sonal, Dr. Ushma, and Dr. Akshaisha. So now we will go with our Saraswati Vandam with the God's blessing. And I welcome Dr. Alpesh Gandhi sir. After that, Sahiti play the Saraswati Vandanam and Alpesh sir CV.
Yes, ma'am.
Sahiti?
Yes, ma'am. Yes, ma'am. It's loading. Yeah.
Yeah.
I welcome our chief guest, Dr. Alpesh sir, was the President Foxy 2020, Vice President Foxy 2013, and Governing Council member from 16 and 17, Chairperson Practical Obstetric Committee earlier, 2009, Vice President Gestosis India chapter, past President, now sir is the President, no, Gestosis India chapter. And
Yes.
past President Ahmedabad Obstetric Society, past Secretary of Ahmedabad Obstetric Society, and convener one of the most successful AACOG 2017 at Ahmedabad. We had the wonderful Republic Day celebration during that period. Past joint convener of SOGAG and past treasurer, I think now he is the president of SOGAG and national coordinator of emergency obstetric care and the program of GOI and FOXY, and the critical care program is done everywhere. And now sir is the representative to TNFOG also. Welcome sir, we need the blessings of your Dr. Alpesh sir.
Thank you, Dr. Sampath Kumari, for the kind words and introduction. Since last many years, we are working together for Foxy, and I enjoyed working with you. When you were working for Adolescent Health Committee, since then we are working together. Thank you very much, Dr. Sampath Kumari and Dr. Madhumita, for inviting me and giving this opportunity.
Thank you.
Thank you for inviting me on a webinar which is on a topic of PPH, the subject which is very, very close to my heart since very beginning when I started working for Foxy, when I was practical obstetric committee chairperson. I develop a course of 3 days, PPH course on 3 days for the PPH, from a cadaveric dissection to internal ligation. All the procedures we were demonstrating, and many live workshops we have conducted during those days. So subject is very close to my heart since then, but lot of changes have been occurred in last 2 decades in the management and in the perspectives. Incidents have also been increased in last 2 decades of severe PPH. Surprisingly, in spite of having so many uterotonics drugs available, potent uterotonics drugs in our hands, even though in spite of it, the incidence has been increased 4 to 5-fold in last 2 decades. May be because of increasing incidence of placenta accreta spectrum, or increasing incidence of previous LSCS, or increased incidence of obesity, diabetes mellitus, gestational diabetes mellitus, HDP, and environmental factors, and so many other reasons. But whatever the result is, there is a definite increase, 4 to 5-fold increase in the incidence of severe PPH. It is now around 25% of the maternal mortality is because of the PPH, and we all know that it's a nightmare. Once patient develop PPH, within 2 hours she can die if timely management is not done. So it's very important for all of us, from prevention to prediction and management and early referral. Everything is very, very important. Lot of changes have been occurred in last 2 decades in the management, and lots of trial studies are there. One is women's trial that was, now all the guidelines are recommending use of significant role of injection tranexamic acid. Now we are very much aware and practicing PPH bundle in our routine practice. Now we also understand the importance of what is shock index, and we are frequently following it in our practice. PAS again is very, very important, and now we also understand the importance of early diagnosis of PAS during antenatal period with the 2D sonography and with the color Doppler, or if required with the MRI. So a lot of changes have been occurred, and we also now know how to manage the cases of PAS. We also understand the importance of the massive transmission protocol, and we also understand the use of ROTEM, from which we can come to know about the components, which component is required and what is the status. So ROTEM is now also very, very important. Recently, we can say since 2021, now Government of India also recognize use of recombinant factor 7A in the management of severe PPH when uterotonics drugs are failed. And now we also are having injection fibrinogen are also available. So a lot of changes occurred in the management of PPH. So it is very, very important for all of us to update ourselves with all such new studies and new drugs and molecules and techniques. So I am very much happy to see that today we are discussing on a topic which is very, very important for our routine practice. पीपीएच के लिए कितना भी डिस्कस करो, it is always less. So it is important always regularly at certain interval we should always discuss and about PPH. We should share our experiences. And I congratulate once again Dr. Sampath Kumari for bringing this very important topic for this webinar. And again, I would like to congratulate Sampath Kumari and Madhumita for a joint program of TNFOG with SOGOG, with so many societies of SOGOG. And I am so happy and excited to see so many friends of SOGOG societies are also here. So thank you for giving me this opportunity to indirectly meeting all of them here. I am also very eager to attend the webinar, and I also would like to learn from this webinar. So my best wishes for the success of this webinar. And again, I would like to congratulate Sampath Kumari and Dr. Madhumita, and my best wishes to Dr. Sampath Kumari for all her future endeavors. Thank you very much for inviting me and giving this opportunity. Thank you.
Thank you, sir. Thank you, Alpesh, sir. This webinar is from your presidentialship only because of the COVID. Alpesh, sir, only promoted this webinar CME, sir, during his COVID period. Though it was a COVID period, we enjoyed, sir, Environmental Day. During your presidentship, a lot of the programs has been conducted, and the Lakshya training, that is the most important during his period, and the release of a post-graduation book. Each PG is having the 2 volumes, sir. Really, thank you so much, sir. Thank you. Thank you, sir.
Thank you. This year we are also coming out with the new edition of this textbook.
Okay, sir. We will get it, sir. Definitely.
Thank you.
Thank you, sir. Thank you. Yes, Madhumita. If time permits, please be stay with us, sir. One topic and one panel only. Okay. Madhumita, Dr. Vidya Prabhakar is there? Okay.
I called.
We will go.
Yes, ma'am. Mahesh Gupta sir also has joined. Yes.
Okay. Then
yes.
During welcome, I left out Bharuch Obesian Society President Dr. Hiral Pandya and Secretary Dr. Falguni Thakkar. Welcome. I left that society. Okay. We'll start with the scientific session with all the permissions of the President and Secretaries of all the OBG societies. We will go with the first session. Yes, Madhumita.
Moving on to the first session, I invite our chairpersons for the first session, Dr. Praful Panagar. Ma'am is a fetal medicine consultant and a practicing gynecologist since 25 years. And she's also AOGS past AOGS managing committee member. And she's trained numerous trainers at the TOT Adarsh Hyderabad, and she's involved in numerous social activities and awareness programs. Next chairperson is Dr. Nisha Patel, who's an infertility consultant and who's now currently pursuing her PhD from Gujarat University. Nisha ma'am and Praful ma'am, are you there? Dr. Nisha? Huh? Dr. Praful ma'am? I think Mahesh Gupta sir? Mahesh Gupta sir, can you introduce Sampath ma'am sir?
Hey, no problem. We will start. Sir is for the next panel expert. No, Mahesh, yes. We can start with the program. Yes. Sagiti, you start presenting the PPT.
Okay, ma'am.
So I welcome you all, the President and Secretaries of all Gujarat Societies. And we will go with that. This is the important topic, which is as Alpesh sir was telling. Now we will talk about the e-motive bundle. I think Dr. Mahesh Gupta sir is also there. He will give his expert opinions during the panel session, which will be conducted by the Dr. So this is a next slide. Next slide. Sakiti. Next slide. This is yes, PPH. As I was telling, the PPH is that mainly the bleeding that happens within the 24 hours is we considered as the primary PPH. And if it occurs in the later stage, we consider it as the secondary PPH. The incidence is 2 to 4%. We do not know which patient will go for PPH. So normally, if the high risk pregnancy cases means, we will be very aware that this patient can go for some complications, and we will tell even the attendant. But some patient without any complications coming by walking to the labor ward, and if she ends in PPH, and sometimes it may end in mortality, it is very difficult to handle. So always identify the PPH at the earlier stage and start the treatment earlier. And if you don't have the facilities, you have to refer the cases at the earlier stage. Next slide. So so these are all which I have told, which are the causes. Uterus can help up to what are all the blood loss which can happen within 10 minutes and during the 6 days, and what are all the complications. Next slide. So the reasons why the mortality for the PPH, because the normal patients, when it is going for the PPH, most of the time they may not have prepared. So that is the reason we tell that all patients, all pregnant women, you should have that this patient can go for the PPH. So in the labor ward, you should have the labor ward kit, labor kit, PPH kit, and PAH kit. So always you should, the fourth stage of labor, that is very, very important. If you are very careful during this fourth stage, that is the first stage dilatation, second stage delivery of baby, third stage delivery of the placenta, and after that, the 1 hour from the delivery of the placenta to 1 hour, you should monitor the patient in the labor ward, whether she is going for the bleeding, pulse, BP, everything. If the blood loss is more than 1 liters only, we will go for the tachycardia and the hypotension. So you should always have our eye is the best measurement. If the bleeding is exceeding 300 to 500 ml means we should start handling the cases, whether with the medical management or with the mechanical management, whatever is needed. The next slide. Sagiti, little fast. So the challenges, which already I have told, the estimation. We are not going to measure the blood loss with the cup or whatever it is. It is only by our eye management. And the second challenge is delayed identifications and referral at the later stage will sometimes lead to the mortality. So whenever you refer the case to the institute where the facilities are there, always give a call to that center, and whatever the drugs you have given, document and then refer the cases. These are all the challenges that has to be dealt during the PPH. Next slide. So the priority, what is the PPH? The priority, always we know what is the cause of the PPH. That is the 4 T's. 4 T's is stone, tissue, trauma, and thrombin. Always once the baby is delivered, the uterus should be like a cricket ball consistency when you palpate. If it is like a tennis ball consistency, means there may be the bleeding can be continuous. So always stop the bleeding before the patient develops the coagulation problems. Arrange for the blood component. And what are all the things, organ damage, if should not go for the organ damage. So call for help, and the conservative approaches should be started before going for the surgical management. Next slide. So first 24 hours, once as I told, the first 24 hours, the fourth stage is the critical stage. That is the golden period. If you miss during this period, then it will be very difficult to revive the patient. Next slide. So the FIGO, need for an effective implementation. This is the prevention. The goal is early, quick management. Whatever it is done, medical management, within 10 minutes, call for help, do the medical management and the mechanical management. Everything should be done within 30 minutes before you decide this management will not be helpful and we have to go for the surgical management. Next slide. So now comes the E-motive trial. Next slide. So what is this E-motive trial? Now we talk about the medical management and the surgical management, mechanical management to stop the bleeding, the medical management, what are all the drugs you are using, mechanical management, bimanual compressions, aortic arch compression, sometimes fully staminate. These are all the methods we are telling. Now this is the latest E-motive bundle. What we are, this E-motive bundle is, the E denotes the early identifications and M is the massage. Always, if you massage the tone, atonicity will be controlled most of the time. So then the O denotes the oxytocin drug, and T is also now it has been included by the FIGO for the PPH. This is the tranexamic acid, which is given immediately after the delivery of the when the PPHs are diagnosed. Then the IV, intravenous infusion drugs, fluids. That fluids also, depending on that only we have to give. If you are going to overload the patient can go for the pulmonary edema. E is the exploration. So next slide. So this E motive bundle is the one thing which has to be followed in the PPH. So the risk assessment, we do not have any risk assessment for the patient, and we do not know which patient can go for the PPH. In spite of this we can have low risk, moderate risk, and high risk. Suppose in the previous pregnancy, the patient had the PPH and whether any other complications, let's say PAH and diabetes, big baby, and multiple pregnancy, if it is present, we can consider it as the high risk cases. And the low risk is the singleton pregnancy, which we do not know which patient can go for the PPH. So we can categorize this, but there is no particular dictum that this patient will go for the PPH. So always monitoring, verify for the tonicity, verify for the trauma if anything is present, verify for the coagulation profile, and then we have to see what is the causes. The clinical features, the findings, always as I told, the 4 T's, atonicity, if the uterus is not contracted, upper segment contracts, lower segment relaxed, the baby is released. But if the uterus is like a bag, relaxed means it is the atonicity. And the tone is good, but still the bleeding is going on, means we have to see whether there is any traumatic, whether there is a episiotomy wound has extended, or whether there is any cervical tear, or whether in the uterus there has been scar. That is the last. Sometimes most of the time we don't go with the fundal pressure. If sometimes if the fundal pressure is given, posterior wall rupture of the uterus can happen. Then the tissue, always once the placenta is delivered, you have to see the placenta is complete, maternal side and the fetal side, all the cotyledons are present. In the fetal side, full membranes are expelled. The coagulation profile first itself we will see whether the patient is having congenital thrombocytopenia and any factor 8 deficiency. If it is present, we think of the coagulation profile. So these are all the clinical features we suspect. The tachycardia and the hypotension only when the blood loss is more than 1 liter. Next slide. The quantification, these are all the methods, gravimetric method and a calibrated plastic sheet and the use of artificial intelligence, visual estimation. But the main is the visual estimation. Now the calibrated plastic sheets are available everywhere. It is where cost is also very less. It can be kept below the gluteal region, and you can, once the liquor and the liquor is drained only, otherwise the liquor and the blood will combine and there may be an increased estimation of the blood. So this blood plastic sheet now we are using in our college to see whether there is a lead point is that 300 ml, 500 ml, about the mark if the blood is going on, then we can see that this patient is going for the PPH. Next slide. This gravimetric method and the calibrated, the plastic sheet only which I told is the collector bag method. The next slide. This is the method we are using, this calibrator, that the blood loss will be mentioned. Below is to 500, 1000, 1 liter. So depending on this value, it can be in the blue color also. It is very simple, but it has to be applied at the appropriate time. The liquor amount cannot be included. Next slide. Next slide. Use of the artificial intelligence in the PPH. So objective. So the visual estimation, that is very, very important. See, now we have the quantification. If the blood clot is with the in the hand of the fist, means it is about 50 ml. If the blood is present in the kidney tray, means it is 500 ml. So like that, we are having the quantifications, but we cannot take it as an appropriate method. But visual examination by practice, what is the blood loss, whether the patient is going for the excessive blood loss. By visual examination only we have to assess. So that is the subjective method. Next slide. So as I told, these are all the with the gauze. What is the size of the gauze? If the full gauze is wet, it can be around 500 ml, full kidney tray means 500 ml. These are all for approximation, we can have it, but this cannot be the exact valuation. Next slide. So this is the picture which has been put. If the blood is spilled out of the table, then we can know it can be more than 1 liter. And the fully continuously it is soaking means it can be 1.5 liter. This is the quantification. For sometimes you can in a labor ward, antenatal ward, eclampsia ward, everybody you can put it just for an assessment. But these are all not the exact value. Next slide. Next slide. So the objective quantification of blood loss is most important. That is, now we go to the, that is examination is the massage. Next slide. What is the massage? See, if you feel that the uterus is not contracted well, means we have to keep our hand over with the palm and give the massage. If you continuously give massage. So as I told, it should be like a cricket ball consistency. If it is a thin patient, we can see the uterus without atonicity bulging over. So if there is the relaxation, we have to continuously ask the attenders also to give the massage. If the patient is, if you have the many paramedicals, they can give. If no one is there, means you can call the attender and put a stool and keep her and continuous massage. Every 5 minutes, if you get massage, most of the time the atonicity will be corrected. Next slide. Whenever there is a PPH, always call for help. This is the way we are going to give the massage. Keep on one over the fundus and with the palm, we are going to massage. When are we going to give this massage? Are you going to give once the baby is delivered? And if placenta has a baby is delivered, placenta is delivered. If you feel that the uterus is bleeding is profuse and the uterus is not felt. Once the delivery is over, means you can see the uterus up to the. If you are not able to feel and if it is seen like a bag, then you have to start the massage. Next slide. The massage, most of the time, it is very, very helpful. Everyone can do. Who can do it? You can ask the attender, and if some house agents are there, you can ask him to do that. If no one is there and the patient is comfortable and the bleeding is less, means you can ask even the patient to do the massage with their hand. So the massage, most of the time, it will be helpful. Every 30 minutes, at least for 1 hour, every 10 minutes, you can see. If it is not, uterus is not, after the massage, if it is not going to get contracted, and without medical management and the massage, only massage cannot be useful. Even after the massage, after 30 minutes, the uterus is felt to be contracted, not relaxed, means then we have to go with the medical management. Next slide. Next slide. So next comes the oxytocin. Oxytocin. Now, previously we used to talk about that Amstel. So once the placenta is delivered, now we are going to give the 10 units of syntocin IM. And that once the baby is delivered, 10 units of syntocin IM. Then you wait for just a few minutes. With the syntocin, the placenta will get separated and you can remove it. Whenever you remove the placenta, always keep even the, always you are going to receive the placenta with the right hand. Left hand has to be kept over the suprapubic region. Don't keep over the fundal region. If you give the suprapubic region, you are giving the, when you remove the placenta, you are giving the counter pressure opposite side in such a way that we are preventing the inversion of uterus. So if it is the PPH, first you are giving the 10 units of syntocin. If the bleeding is more, means you can add 20 units or 10 units in the drip and continuous the drops of 3 drops a minute for in the drip to prevent the PPH. So oxytocin is the best drug which can be used, but it should be used very, very carefully once the baby is delivered, and only you are going to give the IM, and in PPH diagnosis, you are going to give it as the IV. Next slide. Oxytocin, the main point is it has to be kept in the room temperature, fridge maintenance. Always, most of the time, it will be kept in the room temperature. And in that case, only the oxytocin effect will not be used. So always before the delivery only, you have to bring the drug from the refrigeration. So the uterotonics is the oxytocin. Next slide. Next comes the tranexamic acid. So we are talking about the oxytocin. In the meantime, this tranexamic acid is now has been included. This tranexamic acid is 1 gram that has to be given once the placenta is delivered. the FIGO recommends the administration of the tranexamic acid as soon as the diagnosis the PPOG is made. So now it is very, very useful. So it can be given nowadays, it is used even in the cases of menstrual bleeding. So if the bleeding continues 30 minutes, it can be restarted within 24 hours of the first dose, the second also begin. But with the first dose itself, if the bleeding is going to control, means there is no necessity for the tranexamic acid. So the hemotive bundle is examination, massage, the uterotonics, oxytocin, and the tranexamic acid. Next slide. These are all the evidence based. We have a lot of evidences to tell that tranexamic acid will reduce the PPH. Then comes the IV drugs. Next slide. What are all the intravenous fluids we are going to do? What is the drugs we are going to give? This is the pictorial, that is the pin grill. What is to be done at the head end? What is to be done at the lower end? What is to be done at the hand, the hands? That is the IV line has to be started. And on the upper side, we had, when the head end people, they immediately has to check the airway and check the breathing, administer the organ. If any secretion is present, you have to give the secretion. Sublingual misoprostol, we don't give. We go with the, since the bleeding is there, means most of the time, if the patient is conscious, we can give. Otherwise, nowadays, we are not going to with the sublingual misoprostol. If the patient is conscious, it can be given. If she is unconscious, you cannot give this sublingual. And the lower end, what are the IV fluids which we are using is the gauge. This is the IV gauge, which is 20, 18, 16, depending on that, the flow has to be adjusted. If it is the 18 gauge, 250 ml per minute. If it is the 16, 350 ml per minute. If it is 14, 500 ml per minute. Sometimes if you don't have the particular IV gauge, means whatever is available, you use it. And the flow has to be adjusted. Next slide. So the PPHA emergencies, what are all the emergencies which we are giving is mainly the referred PPH we are going to give. Administration kits, as I told, the administration gloves, tonic, whatever is needed, it has to be kept earlier. At the time of the PPH, you cannot search for everything. Always keep the checklist. What is to be given? Oxytocin is ready, or
Ma'am's video.
Madam, you are unmute. Some technique.
Sampath ma'am, I'm not able to hear you, ma'am.
Accidentally, madam has mic unmute.
Is madam muted? I'm not able to see ma'am here.
Yes, madam muted.
Yes,
Yes,
I don't know
ma'am
what
has
happened.
rejoined.
Anyway, we'll finish it. So the PPH responses, tranexamic acid and misoprostol, the PPH tray should be ready and the checklist has to be maintained. Next slide. Nowadays, we go with the anti-shock garment also. If the more bleeding is present and the pulse query, BP query, means whenever you want to refer the patient to the other hospital, with the anti-shock garment can be applied and refer to the patient, and it can be removed depending on the BP and the pulse. The E is examinations, that is the exploration. This is the way we are detect and treat the postpartum hemorrhage. Next slide. Next slide. Sahiti. So this is the always catheterization. Whenever there is the PPH, means we have to catheter. That is the escalation. And if the medical management, we are giving the misoprostol and the tranexamic acid. And sometimes if the bleeding is not getting controlled, you can try even the mechanical methods before shifting the patient to the theater or shifting to the other places. That is intrauterine balloon tamponade. Otherwise, with the Foley's catheter, you can attach the condoms and tie it carefully, and you can fill it with the IV fluids, and it can be kept for 12 hours. This can be also be used. Next slide. The anti-shock garment picture I will show you. The next slide. These are all the methods. Every method has to be done within 30 minutes. You cannot take for bimanual compression 10 minutes, IOT compression 10 minutes, and they should not prolong. The golden hour is within the 24 hours. So you have to decide. If it is not working, you go with the Bagri balloon method. If the Bagri balloon is not available, with the Foley's catheter, you insert and put the IV fluids. It should be like a balloon where the anterior and the posterior wall is not, it is like a what to tell, with the Bagri balloon methods and the Foley's catheter balloon method, normally we see that the uterus is getting contracted. Nowadays, in my college also, there is a study is also going on. Next slide. So now the Paniker's cannula is also available. Now this non-pneumatic anti-shock garment, which I told, this is the garment. 2 person has to stand on both the side, and it will have segments as 1, 2, 3. Next slide, ma. 4, 5, 6. So first has to be applied above the knee and the next slide. So this is the way that garment has to be used. 1, 2, 3. Simultaneously, both the legs, it has to be below the back of the patient. We keep this. First, you apply the 1, the second, 3, and the 5th one will be near the pelvis, and 6th is the ball. So this is the way, below the knee, above the ankle. 1 is above the ankle, 2 is below the knee, and 3 is above the knee, that is in the thigh region, 4 in the pelvis, 5 will be the ball, that is at the level of the umbilicus, and 6 over that. So if you apply this, the main mechanism of this method is the blood flow. From down, it will be pushed to the above. These are all the temporary methods. Shifting the patient from labor ward to the theatre, you can use, and to the higher centers. Once to the higher centers, if they go means, and the medical treatment is given, and shifting the patient to the theatre, it has to be removed from 1, 2, 3, 4 only. First, you have to remove the 1 and see pulse and BP has recovered. Then the 2. If it is not recovered, again it can be kept. This anti-shock garment is in our, when I was with the government hospital, Gosha Hospital, we have used this for 24 hours also. You can remove the 4, 5, 6 alone. And if the surgical method is needed, means you can go with the surgical method also. So once BP and pulse recovers only, you have to remove it completely. The next slide. Next slide. Sakiti, next slide. So now you have the suction cannula method. Sakiti?
Yes, ma'am.
The suction cannula method is also now used. The Paniker's cannula is there. That for the normal delivery, there is one type of cannula is there. And for the LSCS also, you can, that is nothing that it is a cannula which can be connected to the negative pressure. It is applying like a vacuum. So it has to be out. It will suck all the bleeding from the endometrium. It can be kept for 15 minutes. Then you can stop the suction and you can keep the cannula alone. And if the bleeding is again continuous, means you can again apply the negative pressure. This cannula also, like the Foley's catheter itself, it can be kept even for 12 hours. Then slowly you have to remove the cannula. This is the novel methods. This is the latest methods of the cannula, which can be used, and this end can be with the openings. With the negative pressure, the blood will get sucked into it and it will come out. And once the bleeding has stopped, the negative pressure can be stopped. This in the Tamil Nadu government, they have given this anti-shock government and this cannula to all the hospitals, medical colleges, and sometimes with the district health hospital also. So coming to the end, no patient should die because of the PPH. Next slide. So always this emotive examination, massage, oxytocin, and then tranexamic acid, IV fluid, drugs, whatever the drugs, and then the escalation. Always upper end, lower end, and when you start the IV fluids, you have to take the sample of the blood, whether she is going for the coagulations and the blood components, what is to be given, platelets, how much. Now, Sir was talking about the massive transfusion also. If at all needed, everything should be kept ready. Then we can prevent the patient and the PPH death can be prevented. So emotive is the early detection of PPH and treatment using WHO first response bundle, use of a calibrated drops for collection. This is also nowadays available even in the, when you go for the conference in the stalls, there are some, the people are having this stall of the calibrated drape and the bundle of the treatment, which we are continuously doing, the uterine massage, oxytocin, tranexamic acid, escalations of the treatments. This is the emotive. And by the 60% of the PPH can be reduced. Once if everything fails, medical management is failing, mechanical management is failed, only you go for the surgical management, which like Beeling sutures, and finally one the obstetric hysterectomy. No patient, see previously they built Taj Mahal because of the, she died due to the PPH in her 14th delivery. Nowadays they don't build Taj Mahal. We are only at the soap. So always the documentation is very, very important. Whenever you refer the case with whatever the drugs you have given. So thank you for this opportunity, and I request all of you, I am contesting for FOGSI president. Please nominate me and support me. The election time is from August 1 to 10. I need all your supports and blessings. Give us a chance. Thank you so much. Yes, Akiti, you can start.
Thank you so much, ma'am, for such an elaborate and wonderful talk on E-Motu bundle covering all aspects. I'll just see if Dr. Nisha and Dr. Praful, ma'am, are you there, ma'am? Nisha, ma'am.
If there is any questions in the chat box, if any doubts, we can put in the chat box. We can reply. Then we will go for the panel. Magesh sir is there. Meera Rahman is there. If anything doubts, you can put it in the chat box.
Yes, ma'am. Yes, ma'am. So moving on to the next session, we have a wonderful panel on case discussion on PPH. For that, we have our moderator, Dr. Meera Raghavan, and ma'am is a senior consultant urogynecologist and robotic surgeon, and she's also a trainer at HUGO RAS robotic platform. She was the scientific chair of AACC RCOG 2025 and treasurer of SOVSI TN chapter. And we have our expert, Dr. Mahesh Gupta sir, who's the president of Gandhinagar Obstetric and Gynecological Society. Sir is also the national coordinator of PPH Conclave all over India. And he was the past president of Ahmedabad Obstetric Gynecological Society. And he has received Times of India Health Icon Award from Ahmedabad. We have our esteemed panelists, Dr. Reshmi Banerjee, who's the president of Vadodara Obstetric and Gynecological Society, and ma'am is the West Zone coordinator and member of Midlife Management Committee of FOGSI, and also national chairperson of CSR Committee of Indian Menopause Society. Next, we have Dr. Ashwin Machani, who's the professor and head of the Department of OG at SMIMER Medical College at Surat, and he's also the president of Surat Obstetric and Gynecological Society, and he's also a clinician and ethics committee member of SMIMER Medical College. Next, we have Dr. Dashna Pandya, who's a consultant obstetrician gynecologist at an honorary gynecologist at Sterling and Wokat Hospital and Ashutosh Maternity and Surgical Hospital. And she has numerous accolades like National Award winner by and Wonder Foxin Award and Foxy Brahmakumari Award also. Next, we have Dr. Akshay Shah, who's an associate professor at SVP Hospital and NHL Municipal Medical College at Ahmedabad. Dr. Ushma Maniar, who's a proprietor and founder of Devamrut Hospital, and ma'am is also a very active member of Midlife Management Committee of FOGSI, and she has been an organizing chairperson of various conferences. And next we have Dr. Sonal Kodawala, who's a consultant gynecologist and ART specialist at Hyderabad. And she's been a very prominent faculty at various conferences and a trainer of endoscopic surgery since 2006. Dr. Quresha Qureshi, who's a consultant obstetrician and also an infertility expert with over 32 years of experience at Valsad, and she has specialized training in endoscopy and also IVF training, and she was the past president of Valsad Obstetric and Gynecological Society. Over to you, Dr. Meera Raghavan ma'am, for the panel.
Thank you, Dr. Madhumita, and thank you, Sampath ma'am. And thank you all the esteemed guests and panelists and expert Dr. Mahesh Gupta for being here. I will now share my PowerPoint. So PPH, as Madam has already told and emphasized, where literally seconds matter first. So which is why we are here deliberating about this topic again and again to make ourselves completely, versatile with the proceedings of what next without even thinking, because this doesn't come with announcement. It comes at 2 a.m. when we are woken up with a jolt, and then we need to act immediately. So young mother, sudden bleed, room goes silent, BP falling, panic rising. What you do literally determines life or death. The truth about PPH is that there is not lack of knowledge or failure of timing. It's basically acting in time and failure to escalate to the next step or to the next person, and failure of team coordination that lets us down. And we have the golden 60 seconds where we can make a huge difference to the outcome when a PPH unfolds. The ability to immediately recognize that it is PPH, and that moment immediately call for help and institute corrective measures such as tranexamic acid and uterotonics, establish IV access and make sure the circulation is restored by administering IV fluids, all happening in parallel, which is why the pin girl picture which Sampath ma'am showed us, where there is a team at the head end, where there is a team at the arm end and at the perineum, all act simultaneously in synchrony and not in a serial fashion. If this goes wrong, we'll do that. That serial level of step ladder pattern is not the way to manage PPH, which is what we're going to see now. And we need to be aware of our silent alarm, which is the shock index, where the it is determined by the heart rate, by the systolic blood pressure. If it is creeping up more than 0.9, it means imminent danger. And if it's more than 1, it is shock. It acts earlier than BP. So do not wait for your blood pressure to drop. If it's tachycardia with this maintained systolic blood pressure, that itself will raise the shock index, and that is our first silent alarm. Do not become complacent at that point. We need to get acting. So we'll now go to the real battlefield cases, one case per expert, and we will go through them and hear from the experts what they want to share. So we pause at any moment, reset our and think, and then act. Over to Dr. Ashwima. Hi, ma'am. The first case, there is worsening of the bleeding in a lady who has now term pregnancy, delivered 3.3 kilo baby, and suddenly has a big gush of bleed with clot. Her vitals are deteriorating, and the team is obviously looking to you. What next? What will you do now? What must not be delayed? Who do you call? You're telling this to your registrar, say, for example. Is Rashmi ma'am there? Anybody would like to take this question?
Hello. So first of
Yeah, please.
hello.
Yes,
Dr. Ashwin.
Madam, you
yeah.
Hello, I am Dr. Ashwin. I am speaking.
Yes, sir. Yes.
Madam, you have already said that every second, every minute is important. So without wasting the time, we have to start the emotive bundle management, that is IV lines, uterotonics, uterine massage, and of course call for the help, that is for the expert team. It's a teamwork. So we have to motivate the people, particularly if the resident is on the duty and expert is not there, then it should be early call to the expert so that we will not. And meanwhile, parallel all the work should be continue, uterotonics and all these things, so that majority of the PPH with the proper timely management, we are able to control the bleeding. If it is not control and refractory, then and then we have to escalate the, as Madam has rightly told in our talk, that we have to early escalate the things without wasting much time.
So what is the time limit we will wait till we call it a day or go to theater? What is it, sir? 1 hour, half an hour, 40 minutes? What exactly would be the time?
Total management time for the PPH is 1 hour. That is what we popularly known as golden hours.
Golden hours.
Yes, so 1 hour till within 1 hour we have to reach up to the final management, that is surgical management.
Correct.
So for all the non-medical management, not more than 10 minutes to the each management, and within 30 minutes we have to reach up to the decision for the definitive surgical management.
Absolutely.
That should be the one.
And
Absolutely, sir. Thank you.
May I say a word?
Yes, yes.
Yeah, like you said 3.3 kg baby. So
Yes.
I would think about a traumatic this thing also. So I
Exactly.
would call my anesthetist and get it, he should be ready,
Exactly,
because in case
exactly.
within 10 minutes I find that there is cervical tear or vaginal tear or something, then
Yeah.
that anesthetist should be there, because we are working in a nursing home, small nursing home, and not a big hospital.
Exactly,
So
exactly, ma'am.
I would
Exactly.
prefer, yes.
Be aware of the situation we are in, the time of the day, the assistance which is available, the blood bank availability, and the blood availability. Without this
40,
awareness,
what Madam has mentioned.
Yeah.
40 is very much important.
yes,
Yes.
yes, absolutely. So this is a decoy. I just put atonic PPH, but that's a decoy that does not or should not stop us from evaluating all the 40s. Can we have one expert enumerate all the 40s quickly so we can move on to the next thing?
So they are the tone, trauma, tissue, and
Tissue.
chopping.
Yes.
ma'am.
These are the
Thank
four
you.
T's which are required for management.
Thank you, ma'am. So a reality check has to be done every time you evaluate, assess. So evaluate, resuscitate, assess. Evaluate, resuscitate, assess. So we call it the golden era. Evaluate, resuscitate, assess. When we're assessing, we now see that the shock index is rising. As I already said, the moment it hits 0.9, it is danger zone, and which hidden bleeding is possible, and whether you have blood in hand, because time is actually the saver here. So we resuscitate simultaneously. We have already seen the utrotronics. Tranexamic acid. Can one of the panelists tell me exactly when tranexamic acid, what dose should be given, how quickly it should be given, when can we repeat it, what is the benefit?
So Madam has already enumerated in her talk also, tranexamic acid is the now given in all kind of the PPH,
all
irrespective of the
cases.
etiology.
Yeah.
Once you label the PPH, it should be given. It is useful even in traumatic also to little.
Absolutely.
Whatever
So
cause
it
it
should
is
be
there.
given.
1 gram IV slowly over 10 minutes is supposed to be given, or we can even add it to a crystalloid pint
Yeah.
and give it slowly. And we have
Absolutely.
to wait for an hour.
Yeah.
And then we can repeat also.
Repeat.
Madam,
After
we can
30 minutes.
repeat it even after 30 minutes. We don't need to wait for 1 hour.
Yeah, we can repeat it after 30 minutes. Yes. But it should be instituted early as well. That should be very, very important. Thank you. We have now escalated. She's not settling with the medical management. Now what? What is your preference as opposed to balloon tamponade versus cannula? Suction
In
cannula.
all vaginal deliveries, we usually try these days the cannula also.
Excellent.
And balloon. If it is
Balloon.
both the things we try before thinking of opening up the abdomen in all vaginal deliveries. If it
Absolutely.
is atonic, and I would still say that in all vaginal deliveries, I put a speculum, examine the vagina, and because quite
Must.
often that happens.
Yeah,
So
if you're in
that will be
theater, might
first.
as well do a thorough check to make sure there is no trauma.
Yes.
You've made out a cervical tear and then sutured it and made sure there is no broad ligament extension.
Sometimes there may be the
Yes,
multiple.
extension of that hematoma is dangerous because it dissects
Abs-
broad ligament very quickly.
Exactly.
Yes.
And then
Exactly.
it's a mess.
Exactly.
So before it extend to broad ligament, we need to quickly act.
Yes.
Yeah. So I'm going to ask this question. You ask the nurse to do a massage. She says, I'm not able to feel the fundus there. What will we think immediately? And the patient is shocked.
It is a case of
Yes,
inversion
it is
of
the
uterus.
inversion only.
Inversion.
Inversion of
Inversion
uterus.
only.
Absolutely. In disproportionate shock and fundus missing where it is supposed to be is an indication of inversion. And
Inversion.
immediately I have to resuscitate the patient by reposition of the uterus and maintain it in that position and start oxytocin. Otherwise, there is bound to be torrential hemorrhage and further shock as well. Now, with regards to balloon tamponade, what is the maximum amount we can put it in the balloon and what next? How much can we put in the balloon? And what will we do subsequently?
So there are two concepts. One is the fixed dose and one is the only effect of the gravity and result, that is stoppage of the bleeding. So we can start the saline with IV fluids and inflate the balloon initially till up to the 500, then up to 1 liter. And if the bleeding is stopped, then we may gradually stop the further inflation of the balloon.
Absolutely. And we need to make sure the uterus is contracted on top of the tamponading balloon with the continuation of intravenous oxytocin, which we continue at 125 mils an hour with 40 units put in that bottle. That's very, very important for us to do. What is the take home regarding carbetocin? Carbetocin as an oxytocic, can we give the audience one take home point each?
It has a longer life, so it continues acting even after the initial contraction. So I
Absolutely.
prefer it, even we give it IM also. Once this thing is stopped, it gives for continuous for 6 to 8 hours, the effect lasts. So that really helps.
Is it a prophylactic medication for PPH or a therapeutic medication for PPH?
It can be used for both,
Yes,
madam.
it can be
We are
both,
using
but
it as
I use
prophylactic also.
prophylactic.
Yeah, it is mainly for
When we
prophylactic.
suspect
Yes.
high risk to develop my
Correct.
anticipate PPH, then I always use prophylactic.
Prophylactic.
Absolutely.
Prophylactic.
Carbetocin is
Also-
the choice when we have to do prophylactic management of
Yes.
PPH, especially in high risk patients, because it has a longer T half and makes sure there is no additional need for extra dosing or other oxytocic agents. That is the main
Yes.
mechanism of carbetocin. One more advantage of carbetocin
Does
over
not require
oxy-
freezing.
Is it hard?
Yes,
Cold
freezing.
chain is not required.
especially
Yes.
with summer being
Yes.
like this, I think for our country,
Room, it's stable at
carbetocin-
room temperature and onset of action is also very quick, madam.
Awesome. Thank you. Thank you. So
Meera
just
Mahesh sir is also there, no? Meera?
yes, ma'am. Yes, ma'am. We're going to take his
Mahesh sir.
input now because we're coming to the end of the first case. Sir, your words of wisdom regarding atonic PPH. If we were to take home 2-3 points regarding atonic PPH, and this will be it. Is sir there?
I think sir is muted.
I think so.
Indicted.
Mahesh sir?
Dr. Mahesh sir?
Yeah, please tell me. I was busy in OPD. Yeah, what was the question?
No, atonic PPH, if we were to take home 3 important points for us to never forget, what would that be, sir? Like gospel.
Yeah,
Hello.
Not here.
அவருக்கு லிங்க் சரியா இல்லைன்னு நினைக்கிறேன். சரி, go with Ashwin sir.
Sir, I think your signal is weak, sir.
Sir, can I add few lines? Hello.
Yes,
Yeah.
sir. Yes, sir.
We have discussed the atonic PPH in reference to the, I think, vaginal delivery only, but same thing can be happen with cesarean section also.
okay, you are talking about the PPH after normal delivery.
Yes.
Yeah.
Yeah,
But
PPH after normal delivery means that is again anticipate.
So I'm not able to hear. So I'm going to go ahead with the take-home messages from here. Speed is the essence of time, so it saves life. And we need to simultaneously institute parallel actions of resuscitation, evaluation, and treatment. And definitely escalate immediately if one intervention is not working. Second case. Can we have everybody muted? I can't hear very well. This is a patient where she's delivered in the labor ward, para 3, and previously had manual removal of placenta, a forceps delivery this time because of a big baby. She did have some amount of a heavy gush of bleeding, but placenta is not separating. But her bleeding is worsening, and there is vitals deteriorating. And obviously, the team is looking out for you to sort things out. Between Dr. Akshay and Dr. Ashwin, can we take this question?
Yes, madam. Madam, so retained placenta, we need to start oxytocin. That is one. We usually give injection prostrodin, that is carboprost intramuscular. And even if the placenta is not coming out and the bleeding is ongoing, we need to give general anesthesia. We need to have a good relaxation, and we need to carry out manual removal of placenta under good uterine relaxation. And before we remove the placenta out with our hand from the uterine cavity, the oxytocin must be ongoing.
Correct. Correct. And what is the role of umbilical vein oxytocin? Has anybody used that? What is the WHO recommendation?
So there are some different studies said that, but some studies said that if we give the intravenous oxytocin, then it helps to separate the placenta. But it is not proved, so it is not included in the guideline as a standalone of the treatment. But many studies show that it has the little role.
You mean the umbilical vein?
Yes,
in the placenta? Yeah.
Yes.
Yeah. Got you, sir. Got you. It is part of the WHO care bundle where it
Yes.
says, yes, it helps, but should be given within the first 30 minutes. A patient with a retained placenta and bleeding, you institute all the prostaglandins. But if it is just retained placenta but no bleeding, better to wait, because if we institute the prostaglandin treatment, it can cause hourglass contraction of the uterus and avoid the placenta coming out. So it is something to be borne in mind. So just the prophylactic dose of syntocinon and we wait on. But because she is a previous PPH and also a previous manual removal of placenta, we need to think about active management of third stage. That is the message here.
One more thing I want to add is that we have to remember the adherent placenta also.
Absolutely.
Because yes, the previous history of the manual removal of placenta,
Yes,
that
sir.
may also the one etiological factor. So that should be in the kept in the mind.
Absolutely. And also don't forget your broad spectrum IV antibiotics during the procedure,
that is must.
because it can cause sepsis, considering the fact she's already got other risk factors. Thank you. So again, we need to think of all the three as a reality check. Look at the heart rate, systolic blood pressure, always look for concealed bleeding and scribe with the time chart. Otherwise, we will be missing out on time. We don't need to repeat this again. We continuously think about OT preparation and blood. So blood bank to be alerted and his anesthetist to be told much earlier ahead. So if it were to have difficulty in removal of the placenta, manual removal is difficult. What are we thinking here? She's para.
Yeah, just sorry to interrupt you.
Yes, sir.
But one word of caution is that before attempting MRP,
yes,
one should be certain that it is not a acrita.
Absolutely.
So we have to differentiate between fundal acrita and trapped placenta.
Absolutely.
So if it is a trapped placenta, we can go for MRP. And if it is a placenta acrita, and that here the role of postpartum ultrasound came.
Yes, sir.
In postpartum ultrasound, you can differentiate a trapped placenta and placenta acrita. So if it is a placenta acrita, then the management is different. And if it is a trapped placenta, as you say, the hourglass, so the management is a simple MRP. So this is a word of caution.
Yes, sir. Can you elaborate on the postpartum ultrasound features
of
how to differentiate between this?
Yes.
Yes, sir.
It is very important. If it is a trapped placenta, then the myometrial thickness all around the placental mass will be similar or same. If it is a 2 centimeter, then there is all around the mass, the myometrial thickness is even or same. But if it is a adherent placenta somewhere, at that point of time, point of place, the myometrial thickness is less than the other places.
Yes,
so this is the differentiating point between the trapped placenta and placenta acrita, fundal placenta acrita spectrum.
Absolutely. Thank you so much, sir. So not only intrapartum ultrasound, postpartum ultrasound is also crucial with regards to our labor ward. In these type of cases where you'll have to make that quick call, whether you do a manual removal of placenta or be aware that it could be an adherent placenta, prepare for a potential hysterectomy at that point in time. So again, the same thing, proper parallel actions of decisive escalation. The third case, a traumatic tear where there is worsening of the bleeding and the vitals are deteriorating, where the patient has had a vacuum delivery which has failed, and subsequently the registrar has gone on to do a forceps delivery. Now, while the forceps delivery, it was a persistent occipito-posterior, and the head came out sweeping the perineum, and it was a significant extension of the episiotomy which was given, and torrential hemorrhage ensues. What are we thinking now?
A nightmare.
Dr. Sonal or Dr. Darshana?
Multiple tears may be there because vacuum failed, then occipito-posterior, so tear might be extending towards rectum or CPT. We need to rule out properly immediately.
Absolutely.
And speculum or speculum, both in anterior fornix and posterior fornix is burst. To see all around, and exploration of cervix also is very much important, not to forget about cervical tear.
Absolutely. This is potentially could be an annular cervical tear if they have not applied the cup properly or extension of the tear. Absolutely, sir. What else could potentially be injured?
So apart
The
from
cervical tear extension will cause the...
These things should be done under anesthesia in main operation theater.
Yeah, main operation
Then,
theater.
then we can explore it properly.
Yes, yes.
Good exposure
Yes.
is must. We have good assistant, good anesthesia.
Yes.
And because, sometimes this extension of episiotomy goes up to broad ligament.
Broad
It goes in the fornices. So we have to, identify the tip of the and the edge of the episiotomy where it is.
Like
so we need
Alporexis.
proper anesthesia and proper assistance and proper lighting. Then only, so major and OT only is we have to do that.
Sometimes paraurethral tear also bleeds a lot.
And paraurethral tear bleeds worse.
Yes, yes. And we need good lighting and good exposure.
Lighting,
a labor ward might not be the best place to do these things, which is why we need good exposure, good lithotomy stirrups, good assistance, and good lighting, good anesthesia. So regional anesthesia or general anesthesia, whichever is dependent. And simultaneously resuscitate the patient. These are the instances where tranexamic acid has to be given much earlier, and make sure you're not losing blood too quickly and keep replacing it in a 1-to-1 ratio. So can somebody quickly elaborate the principles of transfusion? How do we transfuse?
Before that, madam, may I interrupt for traumatic PPH?
Yes.
Yes, sir.
Yeah, in traumatic PPH, we should first judge that the amount of tachycardia and amount of hypotension is proportionate to the bleeding or not.
Yes.
Because there are two types of bleeding. One is a reveal bleeding that you can witness the amount of blood bleeding. And second thing, it is a hidden bleeding, which you cannot see.
Which is what we have put here. So keep on checking.
So that is more important. If there is a big supralevator hematoma or big vaginal hematoma or big broad ligament hematoma, here the proportion of the tachycardia and proportion of the hypotension is more than the revealed hemorrhage. So if it is a revealed hemorrhage, yes, you can tackle with the vaginal route with good exposure, good anesthesia, good relaxation, good suture material, and good instrument. But if it is a concealed big hematoma, then you need to go for a vascular ligation, that is in the form of internal iliac artery ligation.
So
this
rule
is
of
very
30 is good to monitor. Rule of 30, vitals.
Yes.
Yeah.
So
then immediately we can suspect when we follow we follow the rule of 30.
Yeah.
So here in vacuum delivery or in forceps delivery, we must consider the vaginal wall hematoma or supralevator hematoma.
So we find a vaginal hematoma here. What will we be doing? In this patient, we have found that there is a hematoma. There is one cleaving hematoma which is happening in the vaginal wall because of an extensive episiotomy, and it is going up. What will we be doing?
So with
In
good
vagina-
position, yes, sir.
Yeah, Ashwin, carry on.
In operation theater, again under anesthesia with good position, lightning and assistant, we have to assess the hematoma and we have to drain the hematoma. And once the clot is removed, give the thorough saline wash. Most of the time, we are not able to find the bleeders. If bleeders is identified, then fine and take the stitch. Otherwise, just drain it properly with the saline so that you cannot miss the major bleeders. And better keep it to the open.
And we can try packing also with
Yes.
local.
Yes.
Pack works very well rather than keep on suturing. Sometimes it
Yes.
takes
Yes.
on and on because vaginal wall at the time is so friable.
It's very friable. It's like, clots, which is coming, shreds of tissue coming in the hand. So multiple suturing will cause further trauma. It is better to pack that area, sometimes packing with something which is vasoconstrictive or hemostatic also helps.
Packing again is a controversial.
Not in all cases. When
is,
there is active bleeder, don't pack. But once it's generalized,
Mahesh
use
sir, your
packing.
opinion regarding packing? Mahesh sir?
Vaginal packing.
Yes.
Yeah, for hematoma.
Hematoma.
Yeah, see, in
bleeder
heme-
is not identified. Bleeder is there. We need to explore and suturing.
That we will do.
Yeah, I'll just give you a few practical tips.
Yes, sir.
So in anesthesia, under anesthesia, the bladder is empty, and when you push the fundus up, then you will see a very good space in the vagina. If you want to see the cervical tear, you have to push the fundus down.
Down.
But here you have to push the fundus towards
up.
the cephalic side. So
Yeah.
you will see the absolutely all the fornices. That is one thing. Now, second thing here, the use of big mixture, right angle forceps.
Yeah.
So you can catch a bleeder at the apex if it is seen.
Yeah.
So use a big mixture forceps. That is second thing. Third thing, you don't just approximate the edges, because our general tradition of habit is just we approximate the vaginal wall. Here you need to go for a box suture.
Yes, agreed, sir.
You have to go for a box suture and
Just
big
like-
box suture. Yes.
Just like
So
we do on the
don't just-
uterus. Yes.
Yes. So just don't approximate this edges. You
Yeah.
go for a box suture, the bleeding will stop.
Yeah.
And
Yeah.
if you find a generalized oozing and no particular sputter, yeah, you can give a trial of vaginal packing. If it is only mildly oozers are there, right?
Yeah.
Yes, sir.
So these
Agreed,
are some few practical tips here.
Absolutely. Thank you, sir. So again, the same thing which we will be thinking about. Now coming to this patient who has had a vaginal hematoma. It's really bad. We have tried to suture it. We are packing. She's still bled. And now the bleeding is worsening. And you're now seeing there is no clotting happening there. What is happening here? And what should we be doing?
So this is usually in case of postpartum hemorrhage. If we are very late for the transfusion and we give the excessive fluid, then there may be the dilutional coagulopathy.
Absolutely, sir. Absolutely.
So that thing, prevention is better here. So that's why timely blood and blood components should be started. And we have to follow the massive transfusion protocol from the beginning. Once you label the severe PPH, you have to follow the massive transfusion protocol. It depends in institute to institute protocol. Our medical college have the in first sitting, we give the 4:4. That is 4 RCC and 4 FFP in first round. Bleeding is more and we need further bleeding, then 1:1:1, that we are adding the platelet in the second round. And if some etiology for reduced platelet is there from the beginning, then from the starting 1:1:1 that we are giving. So that will be prevent the dilutional coagulopathy. And once we have not followed this thing and such coagulation abnormality like picture occurs, then immediately we have to give the various blood component, including the FFP and cryoprecipitate. And if possible, then do the bedside testing that
Yes.
rotam and all this thing is there. If
Yeah.
we are fortunate that and we can do, then we can know the exactly which component is deficient. So that
Absolutely.
helps for the excellent guidelines for the transfusion.
Absolutely, sir. Now we have the advancements of rotem and tech, where we can now determine which component is deficient and replace that coagulant component. So further coagulopathy does not ensue, and we will be attacking the thrombin aspect of T's of BPH. Yes, thank you. Who will be very crucial to call at that instant, this particular scenario? Amongst the team members.
I think our blood bank giving us the blood and components
Hemat-
immediately.
Hematologist.
Hematologist and blood bank,
Yes,
because we need to
hematologist and blood.
raise
Yes.
we need to raise the code for massive obstetric hemorrhage
Yes.
protocol, because that word we have to practice in our skill drill and make sure everybody understand what a massive obstetric hemorrhage protocol is, so everybody is on the alert and no delays happen unnecessarily for resuscitating.
Ideally,
this
principle
woman.
of massive transfusion protocol is institute protocol, and it should be the on paper.
Yeah.
Blood bank person should also knowing that once they label the massive transfusion, then immediately they have to send 4+4+4.
Yeah.
Without anything.
Yeah, absolutely. Now we have our senior resident who is assisting the second year PG, where they have done a cesarean section for a previous 2 cesarean section. And now the blood loss is worsening and the vitals are deteriorating. This is called the consultant. What next? With this case, we will finish. And
So,
time.
bleeding in cesarean section, immediately first thing that we have to know is from where the bleeding is coming, whether it is from the upper segment or whether it is from the lower segment.
Correct.
One more thing is the placental site, whether it is in the upper segment, whether it is in the lower segment. So that will determine the line of management and excessive bleeding. If it is another thing, we have to rule out the trauma. For example, if it is due to extension of the cesarean scar or
Yes.
cesarean wound, then probably from the traumatic side, then immediately we have to suture at that side. For example, extension to the one uterine or sometimes extension to the downward toward the bladder.
Yeah, absolutely, sir. And what will be the methods where we can improve visualization and control?
Exteriorization of uterus.
Absolutely, ma'am. Thank you. Thank you. But exteriorization has to also be supervised, because we now know majority of our patients are post endometriosis and
Yes.
ART. They can have posterior adhesions.
Posterior
So,
POD
yes,
adhesions are there.
are terrible. And
Again,
bowel can be
like-
injured. And so we have to be very careful in telling our trainees as well, and make sure they don't injudiciously take out the uterus without informing the anesthetist too, because these tears are very
yes,
bad.
very important. We
Yeah.
have to inform anesthetist that we are
Yes.
exercising the
Uterus. Yes. And then suture it appropriately with the hand at the back of the uterine angle, so that we do not injure the ureter. Very, very important, because the PPH related ureteric injuries are now what we see coming up for any patient with ureteric injury, obstetrically induced. So these are the precautions we take at the time of traumatic PPH during a cesarean. Any expert opinion from Dr. Mahesh Gupta, please?
Yeah, actually, first when you were discussing the DIC, actually my urgent call was interrupting. So DIC discussion was remaining. See, in DIC, a massive hemorrhage leads to the DIC. And at present, in last 3 days, we have 2 cases of DIC still in the ICCU.
Okay.
And that is both the cases after cesarean, normal cesarean section, primary.
Okay.
And one patient, when referral came and reached to the hospital, the hemoglobin was said to be 1 gram.
Okay.
So patient still on ventilator and still everything is deranged, hematuria. And second, just patient operated yesterday night, referral came with inferior epigastric artery trauma, with broad ligament hematoma, and with atonic PPH. And that patient still in DIC, and now it's improving. So DIC is a now major threat to our surgical side of the practice, because once we can complete the surgery, but the DIC management is by the critical care specialist. Now here some myths are there. The one myth is that how much blood is to be given and how it is to be followed up. So everybody is talking in a different way, because many times in the conference I listen some faculties are speaking about the bedside clot test and whatnot. Actually, I can't understand that. What is the bedside clot test will how will that guide you? Because these all cases are the massive transfusion protocol are in the major hospital. So where all the facilities of the PT, APTT, INR and the CBC is there. So every 6 hourly or 8 hourly we are going for this PT, APTT, INR and CBC. And here the one more thing about the one word of the caution is about the fibrinogen. So people are also talking about the fibrinogen, but fibrinogen generally it is a controversial. The fibrinogen is not generally given. It is given is a platelet-rich concentrate, PCB, and the FFP. So
And sometimes
fibrinogen,
it is fuel to the fire. Fibrinogen is always controversial.
yeah. So fibrinogen, so because generally many times I listen that people are talking about the fibrinogen. So fibrinogen is not always is included in the protocol. And this International Coagulation Society said that it is to be followed with the platelet count more than 50. It is to be followed up with the INR, PT, APTT, INR. INR should be less than 1.5. Fibrinogen should be more than 100 sufficient. And the hemoglobin is more than 8. So this how this DIC patient is to be followed up.
Absolutely.
And immediate FFP is, I found it very helpful.
Yeah. So this.
This
And
1:1 ratio is the ideal.
yeah, it is. Yes. It is 1:1:1:1.
Yeah, it's the ideal
And second
ratio.
portion was discussion about what? I forgot. After DIC, what we are discussing just now?
No, sir, we were just discussing
That is
about
the
Suturing.
PPH in cesarean section.
Oh.
PPH and cesarean.
Yeah. The
Yes, sir will give so many inputs.
Yes.
So nowadays the cesarean section is increasing day by day, and the pregnancies conceived after the ART,
Yes.
they are the most high risk cases.
Definitely.
And the pregnancies in the elderly woman, pregnancies with the comorbidity like the hypertension, high BMI, and or pregnancy with hypertension, pregnancy with thrombocytopenia, pregnancy with hepatic diseases, all these cases are very high risk. So if it is a surgical, you say the extension of the uterine incision, lateral side or below towards the bladder, it is carefully the bladder is to be dissected and this suturing is to be done. And if at all, if you are in doubt, then I suggest to take a segment 1 uterine artery. So bilateral uterine arterial ligation is to be done as low as possible after separating the bladder down. So it is very important. So that is this uterine ligation will help. And if you find it is a pure atonic PPH or uterus is relaxed on the upper side, then you can go for the compression suture or my suture, that is Comoc MG suture. So that is our. But when you close the uterus and you close the abdomen, you should be sure that this patient will not bleed. Afterwards. That is always to be seen.
Yes. And if in doubt, in fact, all PPHs, not if in doubt, all PPHs leave a wide pore drain inside the abdominal cavity, 18 or 16, and then come out, because that is very, very important for us to monitor, even if the patient has any collection later on, or a hidden bleeding will then become revealed. Thank you, sir. Thank you for that input, especially about elective cesarean section list. Elective cesarean section list is no more a junior's play. It is always to have the senior most around with supervision they are supposed to do, because these are the ones where we literally open up a Pandora box and we find all kinds of surprises and complications, especially with the rising comorbidity and challenges technically which can arise due to cesarean section. I'm sure what Dr. Mahesh Gupta sir mentioned about an inferior epigastric would have been a previous multiple section and an injury to the inferior epigastric.
Here the one word of caution for Misga-Lodach technique also.
Yes, sir. Thank you.
Because
Thank you.
In last 3 months, I have encountered 3 inferior epigastric artery, rectus muscle wall hematoma due to inferior epigastric artery avulsion.
So
Three.
the reason being the over enthusiastic assistant on the other side puts it under the rectus rather than under the peritoneum.
Yeah, surgeon is also enthusiastic, and more enthusiastic is assistant.
Yeah.
So he is stretching muscle on his side, and surgeon is stretching muscle on his side. And if accidentally fingers will enter in between the muscle and the peritoneum, then there are all chances that inferior epigastric vessels will avulse.
Yeah, more than Mishka Ladakh becomes a Lord Narasimha technique for many. So unfortunately.
Yeah. So if you want to go for Misgao Ladakh technique, then put an incision, skin incision as a jewel point. Don't do with financial incision. Yeah, because there are chances of vascular injuries.
Absolutely. Very important practical technique point. And also not to forget the 3 important aspects. Correct your calcium when you always do massive transfusion, because without calcium being normal, none of the factors will act. Make sure patient is not hypothermia, maintain normal temperature, because then again, the coagulation factors will not act. Make sure the patient is not becoming acidotic. Again, the factors will not act if the patient is acidotic. So constantly recorrect these and monitor these as well.
So after every 3 transfusion, actually,
we have to
give calcium gluconate.
Calcium. Correct, sir.
Sometimes empirical vitamin K also helps.
Yes, absolutely. So tranexamic acid, give it in 3 hours, reduces mortality, repeated needed. Massive transfusion, all of us have given important take-home points. The mistakes usually delay in escalation. We are tuned to thinking sequentially, but we need to think parallelly. We should never ignore any trauma, so make sure patient is dry before you leave the field of surgery, and avoiding hysterectomy to the really late point. These are the usual problems. So closing with the 10 commandments for management of PPH: act early, do not act alone, call for help, think of tranexamic acid early, keep thinking the 4 T's and rethinking them again and again, set your action mode in parallel steps, escalate immediately, think of tamponade early, operate when needed and when optimum, and save the mother first, and every second counts, which is why I put for PPH, every second comes first. Thank you. Thank you all. Thank you, especially Dr. Mahesh Gupta, sir, for sharing all valuable practical points. That was very nice. Thank you so much.
Thank you. Thank you so much.
Thank you.
Chennai workshop also, Mahesh Gupta, sir.
Yes, sir. Thank you. Thank you all. Madam. That was wonderful. Thank you so much.
Thank you all. Really, it was wonderful.
You,
Mahesh sir, thank you. And all the panelists, good interactions. And our moderator, always.
And I wish all the best for you, Dr. Sampath.
Thank you so much
for your election. Yeah. Thank you.
Thank you
so much.
Good night. Good night, Madhumita. Bye.
Yes, sir.
Yes, sir.
Madhumita, formal word of thanks. I request all the parents and secretaries who have joined, please support me and nominate me for the post of FOG president.
All the best, ma'am.
Thank you.
Thank you. Thank you.
All the best.
Madhumita, vote of thanks.
Thank you.
Thank you. Thank you.
Best wishes, madam.
Thank you.
Thank you. Bye.
Coming to the end of this
Bye.
session, I extend my heartfelt gratitude to Sampath Kumari ma'am for bringing us this wonderful webinar, and grateful to our chief guest, Dr. Alpesh Gandhi sir and Dr. Vidya Prabhakar ma'am. And I'm grateful to all the president and secretaries who have joined, who have spent time and joined, and for all your involvement. Thank you very much. And I thank our expert for the panel, Dr. Mahesh Gupta sir, and our esteemed panelists, Dr. Ashwin sir, Dr. Dashna Pandya ma'am, Dr. Ushma Maniar ma'am, Dr. Akshay Shah, Dr. Sonal, and Dr. Kuresha for the active involvement and for making this panel such an interactive and informative one. And I thank all our delegates who joined today in large numbers. And I thank Sahiti, Shripriya, and Shield Connect for your technical support. Thank you, everyone, once again.
And thank you for conducting the panel so well. Thank you.
Thank you.
Okay.